I think we'll kick things off again. Welcome, everyone. Good afternoon. I'm Eric Weissman, Vice President of External Relations for a group called Centrifuge. For those of you who aren't familiar with Centrifuge, we're the region's startup catalyst organization, founded a little over 7 years ago by the big co's that call Cincinnati home as a way to foster innovation and entrepreneurship and economic development by not depending completely on those big co's. By focusing on startups, by focusing on entrepreneurs, and really galvanizing the community to move together as one. One of the great partnerships that we have is with the Health Collaborative, and one of our longtime supporters, one of the founding members of Centrifuge is Cincinnati Children's. So it's very fitting today that we bring both of them to the presentation to talk about crisis communication. And, I've known Craig for a number of years, and we've done a number of events here at Centrifuge, combining with the Health Collaborative. And when all of this was, kind of kicking off, it was really cool to see that this was happening in our backyard. All of this just massive amounts of collaboration, massive amounts of data. So when Craig and I were just touching base and he was going through like all of these different myriad data fields, well, to me, that sounds like a startup opportunity. That sounds like something that would be cool to share with our community about how do you make sense of all this? How do you combine all of this in very quick, very real time that is very critical information? We've brought Dr. Peter Margolis on from Cincinnati Children's. I will let both of them introduce themselves. But over the course of this presentation, we're going to go into these various data fields that we have and how they aggregate this, what is used with that information, what decisions are made from that information. We'll save some time for questions at the end. But if you do have questions, you can drop them in the chat and we'll hit those as we go. There will be a survey that goes out after this session is over, but thank you everyone for your time, and thank you Craig and Peter for your time and for your involvement on behalf of the entire community of what you guys are doing. I'm aware the time is scarce. I'm aware that you guys put in all sorts of hours. Every time I talk to Craig or Krista, and it's at the Health Collaborative, it's a Friday, I say, have a good weekend. And their first response is, what's a weekend? So I really appreciate you guys taking the time today. But Craig and Peter, if you want to introduce yourself, and then Craig, you can go ahead and get started.
Okay, great. Thanks, Eric, and thanks for including us. Thanks to all you for joining and the work that you do in our community. My name is Craig Bramer. I'm the CEO of an organization called the Health Collaborative. You probably haven't heard of the Health Collaborative before. Our work is generally behind the scenes. And what we do is work to improve health and healthcare across Greater Cincinnati by bringing together those who provide care, those who pay for care, insurance companies and employers, those who deliver care, docs and hospitals, and those who receive care, and to make sure that health and healthcare to do our best to make sure health and healthcare is a competitive advantage for Greater Cincinnati. About half of our work is digital, so we move about 15 million clinical results a month electronically across 10 large systems, 10,000 providers, about 4.5 million lives in our identity management platform. We also run large-scale improvement initiatives, including what's now the largest in the country primary care payment reform demonstration with 560 practices across Ohio. And one smallish part of our work has been that we are the designated disaster response coordinator. And so, you might have seen that we ran a drill at the Red Stadium last summer with like 300 volunteers all painted up to look like they're victims, and did a bunch of drills and training over the years. Obviously, that has gone from a relatively small part of our portfolio to all-encompassing now. And as Eric mentioned, it's been, for a lot of people on our teams, children's and elsewhere, it's been quite a wild ride of nights and weekends, and but hugely honored to be in this support role. I'll turn it over to Peter, but just so you get it in your head, I'm kind of the operations policy guy. Peter's the genius. So Peter's super smart. He won't tell you this, so I will. really well respected across the country and even across the world in his improvement work. And so he and I have been buddies for a long time, and we've really both, I think, are so honored to be digging in on this topic. Peter, over to you, sir.
Thank you, Craig, and thank you. I should have you make these. I'm glad this is recorded because I can send it to my dad. So I'm Peter Margolis. I'm a general pediatrician, epidemiologist. My job at Children's is that I'm co-director of what's called the Anderson Center for Health Systems Excellence. That is the group that supports the quality improvement activities across Cincinnati Children's, and it also supports health outcomes, research, innovation in the institution. And a lot of the work that we do focuses on changing big, complex systems. And sadly, we're facing that challenge right now in the middle of the COVID pandemic. And I guess that's what we'll be talking about. So I'll turn it back to you.
Cool. Thanks, Peter. All right, so my screen's locked up, of course. Bear with me, sorry. It's only been 10 weeks. You'd think I'd figured out Zoom by now. Eric, we tested this before and I literally cannot scroll arrow.
Would you like me to do it?
Yeah, do you mind?
I'll go grab the present. Oh, if you've got it, Peter. There you go. Awesome.
Let me just. Okay, Craig.
All right, here we go. All right, so again, I already mentioned the Health Collaborative. Our vision is that Greater Cincinnati is healthy by design and everyone's connected to quality, affordable healthcare. And our mission is to do all that with data-driven improvement. And so in our world health sector, we call this the triple aim: better health, better care, lower cost. Next slide. And again, we're a neutral forum for all these health and healthcare stakeholders to come together. Our board of directors, for example, includes all the hospital CEOs, health plan senior execs, purchasers, and civic leaders, health commissioners, and chamber of commerce leaders, et cetera. All right, so here's our agenda for today. We're gonna talk about a little bit how the work is organized. We wanna go a little nerdy on data dashboards and share with you how we're building these dashboards and where these analytics and bioinformatics assets are sourced and built. We'll talk a little bit about tech. Eric, we'll defer to you to moderate the Q&A section, but if people are interested in working in the digital health space, you need to understand the health care specific specs and ontologies and APIs and all that, and we can jump into that. And then we'll wrap up and then we'll have conversation. Next slide. All right, so I'm going to talk about the problem here. The deluge of information. I'm not going to read all this, but as you can imagine, you know, we've got complex multidimensional interventions to instantiate here locally and take account for local factors, and so it's quite vexing with all the data. Adaption, we have to modify to our local context. We have to implement so that everybody knows not only what to do, but how to do it, and we learn from each other, build a learning system. Command and control operations are centralized. When they are centralized, we don't really always give opportunity for innovation, and so it's a challenge of how do we help a broad group of people make decisions collectively, but not be command and control. And integration and coordination. We want to make sure that to the greatest possible extent we're coordinated with the broader ecosystem, not just health and healthcare, but schools, business, others. Scope of the challenge. So there's 14 counties, Greater Cincinnati, 3 states. And as you'll see in a little bit, that's, you know, everything's in triplicate when we're talking about state data, state policy, state regs. We've got about 227 nursing facilities with 17,000 residents, 32 prisons or correctional facilities with about 9,000 residents, a bunch of shelters, halfway houses, group homes, 18 hospitals, 630 businesses with about 630,000 employees, and 517 census tracts, of which 140 are in poverty areas. We have testing locations and results, pop-ups, labs involved, various labs, hospitals, primary care, and then we have tracing, isolation, and quarantine that we're all learning a lot about with 20 approximately health departments across our jurisdiction, across our region. So it's a lot. What do we need to do? We need to activate an emergency operations center and establish a whole of community incident management structure. We have to really understand in real time our spread. We have to slow and reduce transmission. We have to focus protection on high risk groups. We have to reinforce and expand health system surge capacity and make sure healthcare operations are available and avoid high mortality rates. We have to expand communication and community engagement, and we have to mitigate economic and social consequences of the pandemic. And when I say we, I'm not talking about me and Peter, I'm talking about all y'all on here, all of us.
And Eric, when Eric commented that this is what is turning a 5-day-a-week job into a 7-day-a-week job, I think, Craig, this is how you're spending a lot of your waking hours.
Yep. You too. All right, so just FYI, the state is divided into regions and zones. We're Region 6, Zone 1, Zone 3. The HHS Office of Assistant Secretary of Preparedness and Response supports, from DC, supports the Health Collaborative. And again, that's to do drills. We manage the regional cache of supplies. We manage the Greater Cincinnati Disaster Coalition, which is all the cast of characters involved in disaster response and resiliency. A lot of education and training. The cache I mentioned, when you drive by a hospital, if you see its tent, it's likely to be the Health Collaborative's tent. We manage PPE and ventilators for the region and do a lot of that behind the scenes sourcing and group purchasing. We manage the drills, and then we also are the public information officers for the region. So every day our PIO, public information officers, work with all the health systems and public health officers to make sure that our messaging is as coordinated as possible. More to come on that. So what we did early on was we established a multi-agency coordination. This is incident command structure for those who might have been in the military or have familiarity with this work. The leadership, the steering group is comprised of three, the MAC is comprised of 3 steering groups. And the health system steering group is all the CMOs and COOs of all the major health systems in the region. And, you know, that was the group that during the really terrifying period was every 7 o'clock every morning, weekends included, looking at some of the data that you're about to see from Peter. Then we have a public health steering committee that is all the public health commissioners, about a dozen. Then we have a congregate care steering committee that includes a broad swath of nursing homes, congregate living facilities, treatment centers, jails, et cetera. And that all wraps up to the MAC, and the MAC is co-chaired by Dr. Rick Lofgren, the CEO of UC Health, and myself. We are looking at all those locations that I've talked about. We're working to coordinate all these sort of major categories: testing, tracing, containment, enforcement, communications, supply chain, hospital capacity management, et cetera. Our enablers are data platform and dashboards, modeling and analytics, systems measurement and improvement, knowledge sharing and learning. And it's been very cool working with the Anderson Center because they have really, with Michael Fisher's support, really applied state-of-the-art improvement science in parts of our health sector that heretofore have not really embraced those methodologies, public health and nursing homes and others that are really throughout all this, learning best practice improvement methodologies. And so here's an example of some of the work groups. Pretty much every topic you can think of that touches COVID-19, there's a work group for. We estimate there's about 300 people involved in that whole structure that I mentioned that cuts across the community. Next slide. So we're going to go on to, that's it for how we're organized as a region. We are going to move into the analytics and data work. And so, the idea here is a population health information exchange, which is rather theoretical in the United States. It should exist as a country. It doesn't. It should at least exist as a state or region. Generally doesn't, but this is the work that we're all about, is making sure that our community, at least Greater Cincinnati, is at the state of the art. We have a lot of pre-existing building blocks to work from, included the orange one up there, which is the Health Information Exchange. We call it Health Bridge. That's managed by the Health Collaborative. It was one of the first in the country to start moving clinical data electronically, started 18 years ago. And that's how we're able to manage all those clinical results delivery. So really leveraging that Health Bridge platform, which has interfaces with essentially all providers in Greater Cincinnati of the hospital and physician groups. We also have hospital lab and data coming from the Ohio Hospital Association, the Ohio Department of Health. SurgeNet is a platform that we manage that keeps real-time analysis of bed capacity. So some of the data that Peter will share around ICU utilization or capacity and med-surg capacity comes from that. When things get really bad, we get it updated every 4 hours. I'm not sure what our cadence is right now, but 24 hours a day. So we have real-time look at the whole ecosystem. Local health departments, Ohio Disease Reporting System, aggregated data from New York Times and elsewhere, contextual data from Google and elsewhere. You'll see a lot of that. And that informs all these groups in the green, the MAC, but also increasingly business leaders. And Eric, at the end, I would like to come back and talk about our announcement today with the Chamber on our regional coordination for communications.
Sure, I'll write that down.
Beyond that, I think, Peter, I'm over to you, my friend.
Okay, well, so the challenge that we're facing is that this is as Craig mentioned, this is a very complex system with lots of stakeholders who are trying to work together. Public health can't work in isolation without the hospitals, which can't work without places where people are living. And so for decision makers to make decisions, they need information from lots of different data sources, which, as Craig said, has been a necessary component of supporting the decision, the work that's taking place. And what we're faced with is the lack of a way to integrate that data. So to some extent, what we've been doing since we started has been piecing together these various streams of data into a situational awareness capability that operates on a daily basis. It's not exactly pretty, but it is. We've made a lot of progress, and what I want to spend some time talking about is just what that looks like. So the interesting thing about epidemics, and I am an epidemiologist, but I'm a health systems epidemiologist. I'm not an infectious disease epidemiologist. And in some ways, I'm a little bit envious of infectious disease epidemiologists because they can reduce complex problems like pandemics to math. And so this is a mathematical, this is the basis of a mathematical equation that describes what happens in an epidemic. And if you look at the top line, that's probably the most important part of this slide. So people are, before coronavirus, everybody in the world was susceptible. A certain percentage of people are exposed. Of the exposed people, they may go on to become infected. And then as a result of the infection, you may end up, if you look down, they might end up being quarantined. They might end up, the H stands for being in the hospital. They might die, the M is for mortality, or they might be recovered. And at the time they recovered, they're removed from the population. So many of you have heard about this statistic called R0 or R naught. And that's a statistic that is used at the beginning of an epidemic to describe the number of cases that a single an infected individual will cause. And when an infection is introduced into the population with no prior immunity. So at the very beginning of COVID-19, the R naught for the infection was about 2.5 to 3. And to kind of put that in context, measles has an R naught of 16. So much more infectious disease. As the infection, as people become infected, we use another statistic that we call R effective or R sub T, or the R coefficient, which is the infection, the number of cases that any new case will generate, and that's an important metric for tracking the epidemic. So let me show you a little bit about how this works. So this slide is from Wuhan. It's from a paper that was published in JAMA in the middle of April. And what this slide shows is the plot of the R number, or the R sub T, over the time of the infection. You can see it starts around January 1st, and it ends at the end of March. And the bars are the different things that took place in China to try and control the epidemic. You can see that one other part about this statistics is that if the R is greater than 1, that means the infection is spreading. If the R is less than 1, that means that the infection, the epidemic, is being contained. So as progressive series of interventions took place, the lockdown, centralized quarantine, universal symptom surveys, you can see that the epidemic was extinguished. So this was very useful. One of my colleagues at Cincinnati Children's, David Hartley, is an infectious disease epidemiologist and pandemic expert. And he wrote an editorial on this paper that was published in JAMA. And what he said was that the paper hints at a possibility that you could use data to support real-time evaluation of public health interventions during an ongoing pandemic as a way of monitoring infection rates and then finding a way to get the R number to go down below 1. And so that's the work that we're doing now. And I'll have to confess that we're, as a community, not being all that successful. And that's something that we can talk about today. So what can you do to reduce that R number that's here in the equation? There's a limited number of things, but we have to be able to figure out how to do them well. The first is universal protection of people who are susceptible to the infection, hand washing, not touching your face, wearing a mask. The second is widespread rapid testing to detect new infections. A third is effective outreach and tracing and isolation of cases. And then a fourth is ongoing assessment of the immune status in the population, because we know that when we get to about 60 or 70% of people who are immune, we reach what's called herd immunity. And when you get to about that percentage of people who are immune, again, the R will go down below 0. So we're using here, our goal has been to use data to inform this regional response so that we can support all the different stakeholders with sustainable, actionable data to guide their planning and to work towards a set of resources that can be shared, data resources that can be shared with the public. We're very, very fortunate to have the Health Collaborative in these dual roles of being the health information exchange and being the convener, being the source of pandemic preparation. Very few places in the country have that. And the aspiration nationally has been to use electronic health records to support this kind of situational awareness, but very few places have the ability to do that. So these are the data. This is the dashboard that all of us can pull up every day for the state of Ohio. The challenge is that we are operating in a 14 county area. So we're interested in what's happening in the state, and we can see what's happening in Hamilton County. But for our work in these 14 counties, we need to be able to actually combine all the data across all 14 counties. And we also have to be able to get the data, the various data streams that are feeding this and additional data streams that Craig showed in his previous slide. So let me show you where we are today. This is where we started. So beginning in the middle of April, David Hartley, who is, as I said, the person who's the expert in this, was able to start using the data that was available from the state to calculate the R number. And so beginning in the middle of April, we were able to calculate this on a daily basis. What's taken place is this. So these are data from yesterday. This is where you can see, this is where we were in April. And what you can see here is this chart shows two things. These are the number of new cases every day. And on the top is the R number that corresponds to that. We can talk about the calculation. This is for Hamilton County. On the right is for the 14 county area. It's a little bit of a depressing graph because you can see the dramatic increase in cases over the last few weeks. And correspondingly, we started out with the R of around 2 or 2.5. It came down under 1. We had a couple of peaks and valleys, and now we're back over 1 in our community, both in Hamilton County and in the 14 county area. One of the things that we've been doing is putting this on a map because we're also able to calculate R for each of the counties. Red means that where the county is statistically over 1. Yellow means that the county, that the R is, 1 is within the estimate of R. And you can see that none of the counties are under 1. So we're not in a good spot right now. This is data.
Sorry, you might want to explain the confidence intervals and explain why Clinton County is above 1, but we don't color it red, for example.
Sure. So when you, thanks, Craig. When you look at this data here of the R, you can see the slightly gray coloring. This is a confidence interval on that estimate. So we know that the estimate is somewhere, think of it like hurricane tracking. There's the projected path, but then there's the uncertainty around the path, and that's what the gray bar shows. And here you can see that the lower limit of the gray is above 1, so we know that's that the estimate for R is over 1. For other counties, I didn't include, well, for other counties like Clinton County, where the R is 1.4, the number of cases is very small. You can also, the number of cases is small, and so the estimate is not very precise, and it's possible, and in fact likely, that the R is it's hard to say anything about where they are just because of the small number of cases that they're observing. So the R is that's the goal. We want to get to the epidemic suppressed. To do that, we've got to get R less than 1. In the meantime, we have to operate the system. And so one of the things that happen, so we look at other things, which are health system demand. This is a plot showing the demand in the region's ICUs. Each one of these blue dots is the data for an individual day. And you can see that what's happened since April was that we had a nice steady decline in patients in the ICU until about 2 weeks ago when the rate started increasing. We're on our way back up. These are hospital data. These are the number of patients in the hospital. We peaked at about 155. You can see, again, the same pattern. We went up beginning in April. We've had a decline, and now we're on a very steep increase. And Craig just mentioned before the call, we've all become one of the hospital CMOs said that in the absence of baseball, the only statistics that we have to follow are COVID statistics. And so all of us are waiting every day to hear what the number of people in the hospital is. Today, it's not so good. Our projection is that we'll continue to go up. And today, in fact, we went from here, which I guess is about 145 to 147. So not exactly going in the right direction. What does that look like at the hospital level? This is a plot of the percentage of beds that are occupied for the region for med-surg beds and critical care. You can see that we're at about 80% occupancy for critical care and about 77% occupancy for med-surg. If you're reading the newspaper and reading about Texas, you might start to worry about that a lot. It turns out actually that most hospitals run at about 80% occupancy. So another thing that we look at, which I did not include, is the percentage of surge capacity, what's called surge capacity. Hospitals have a certain amount to flex up, certain amount of capability to flex up and admit more patients, accommodate more patients in the hospital. And so this is one number that we track, but another thing that we track is how close are we to the surge capacity of the hospital? And we've been running we've been running at about 60%. The hospital leaders have said that once we get about 75%, then we're really starting to push the point where we need to start thinking about shutting down elective procedures again.
Hey, so Peter, let me just say a couple of things about that one. First of all, yeah, all the hospital data, specific data, we cut by every facility in the region. And it's an unprecedented level of transparency that all the CMOs and COOs share every morning with each other, their internal statistics. Also, there's a lot more granular data we have around census tract positive sites. There's a lot of data that we're not allowed to share publicly for various different reasons, but know that this is like the high level aggregate, but this is a very much more detailed. And then also I'll just point out that these color bars on this slide are predetermined thresholds. And so at every level, we as a group have already determined what happens when we get into one of these zones. So for example, the red zone is when we fire up the convention center. As you may have seen a couple months ago, that was a good drill for us. So we now have a very detailed playbook. All the equipment is standing up very quickly. And so that's what the color codes mean.
Thanks, Craig. So what we're walking you through is how we look at the spread of the epidemic. We've shown you the main outcome, which is the spread, R. We've shown you the impact of having a lot of cases, which is occupancy and in the ICUs and the hospital itself. And then the other thing that everyone is talking about now is, well, as testing becomes more available, perhaps what's going on is that we're just seeing more cases because we're doing more testing. And so one way of looking at that and one way of thinking about that epidemiologically is what's the burden of disease in the community? Because if you do a lot of tests, you would expect, and the burden of disease is low, you would expect the percentage of people who are testing positive to be low, and not many people would be admitted to the hospital. What we're seeing is a certain percentage of patients who are infected will get admitted to the hospital. So that's one way of looking at the disease burden in the community is the number of people admitted to the hospital. The other is, as you test more, if the percentage of tests should go down. And one of the things, and so that's one thing we've been looking at. And then we've also wondered about, well, what's causing this recent increase? Is it old people getting sick in nursing homes? Or is it the fact that we're reopening and now everybody's going back to work? And what you can see here is a plot of the percentage of positive tests by different ages of people who are being tested. So again, the thing to pay attention to here is each blue dot is the percentage of positive tests on a particular day. So here's 2 days ago. The orange dots are what happened on weekends because we know there's fewer tests. And what you can see is that the percentage of positive tests varies on a day-to-day basis, but on average, it's starting in April is around 10%. And this is for a group of 20 to 30-year-olds. As testing increased, the number of the percentage of people as expected who were positive went down until about 2 weeks ago when the percentage went back up. So this is not a good sign. This is what we might expect. Young people go out, they're not practicing, they're getting together in groups and they're getting infected. What you don't see that pattern in other groups, 30 to 40-year-olds, 40 to 50-year-olds, 50 to 60-year-olds, 60 to 70-year-olds, and 70 to 80-year-olds. So the data are telling us perhaps what's going on is there's a shift to more disease in younger age groups. These are the data that we track these are the overall aggregate data. This is the percentage of positives. We started out at around 10%. It's dropped to around 5%. And more recently, it actually dropped to around 3%, and now it's come back up. The bottom of the graph is the number of tests being done in the community. You can see that it started out very low and it's going up higher and higher. And then the last thing that we've looked at is there are a lot of other nice data sources. One of them is from Google. So every few days, Google publishes mobility data that shows people's mobility in different parts of the community. Here's grocery stores and pharmacy, here's residents, here's retail and information, here's workplaces. And these are data from, this one is from the 12th of June. What you can see is, here you see the impact of social distancing. People stopped going to the grocery store, they stopped going to retail stores, they stopped going to work, and mostly were hanging around at home. And over the last few weeks, as the community has opened up, you can see an increase in retail and recreation. So let me just stop there. I think we have a small group of people on the phone. We could stop for questions here, or Craig, maybe you want to just talk about this, or?
It's a picture of the convention center turned into a hospital.
So this was the decision.
So
yeah, go ahead.
No, sorry.
I think one of the ways in which the data were used was to inform a decision, and maybe you could talk about this, Craig, about whether or not to actually open up and the convention center, and how the data actually played into that decision.
Yeah, so obvious point, but the last thing we want is to be making emotional or political decisions at this time. We want data-driven decisions, and so it's very helpful to have leaders across the region, infectious disease docs and epidemiologists and hospital operations people all working together to agree on thresholds and a data-driven strategy. You know, it's not perfect by any stretch, but anything that we would do in this region relative to the COVID response on the health side, pretty much metric driven at this point. And again, we have now a very detailed playbook for how to stand up the convention center, how to do, another thing we didn't mention, but is pretty unique, is that when we got into the heavy surge and we're prepared to do it again, we turned on a company that's a subsidiary of Mercy Health, Mercy Bon Secours, and it essentially centralizes triage and transport for the whole region. So it takes all that real-time data around bed availability and ICU capacity and ventilator capacity, and then optimizes our whole region. So in an instant, when we get in one of those upper bars, it's almost like our whole region, competing hospitals, turns into one health system with one central brain over how to best allocate resources. And that gives us confidence because it helps us know that we can maximize our existing capacity and footprint before having to turn on these ancillary resources.
Maybe we should, Eric, should we take
Go to questions? Sure.
Yeah, let's do that.
So there's one in here from Scott. Scott, thanks for your question. Basically, what does the data look like for hospitalizations in patients going to ICU by age? So, if you didn't have that, can you speak anecdotally to that?
Yeah, so there's a little bit of a shift to younger age group. I think the median age has come down by about 10 years. So as we see, so it's what we've learned is that this is a disease that is, the impact is much worse if you're older. But as the number of cases, there are still a certain percentage of young people will get admitted to the hospital, and so the absolute number of young people being admitted is actually going up as more and more young people are getting infected. But it's
yeah, and I'll just add, Eric. The reason that Peter and I are excited to do this and other things like this is not just to like geek out on data, et cetera, but to really try to stimulate action. So our hope is that this time that you're investing is motivational for you to figure out what you can do both in your personal and professional world, but also in your entrepreneurial minds, because there's all kind of problems that need solutions here. But I'll just give you an anecdote. I don't think this is a HIPAA violation. There's a hospital recently in the past couple of days that admitted a 28-year-old into an ICU for COVID-19 who had no pre-existing conditions. So we really need to dispel any unfounded confidence in our younger population that they're free and don't need to worry about this. In fact, it's becoming increasingly clear that even people who might sail through the crisis of the disease may have longer-term challenges to deal with over the course of their life. So this is not something to be messed with. It's not just the flu, and we know that young people are vectors for more vulnerable citizens. So we really need the younger generation to be serious about this.
Yeah, this is it's sobering stuff, and I really appreciate what you guys are going through, and I think your metaphor of hurricane tracking is really good, because you kind of like here's where we think the hurricane could make landfall based on all of these different conditions, and if it does, this is where you guys we need to do this and this and this, and let's watch that hurricane. So you're like the Weather Channel for us.
Yeah, it's all about hope for the best and plan for the worst.
Yeah. So another question from Elisa. Elisa, thanks for joining us. A summary of the key challenges that need to be solved to help us focusing on some of the bigger issues. And maybe, Craig, this is a good segue into the announcement today, the regional COVID crisis communication center.
Yeah. In public health, communication is part of the intervention. It's not just promotion or telling people what you're up to. It is part of the intervention. It's probably obvious to everybody. So we have to have best-in-class communication, and it has to be highly coordinated across multiple sectors. And so today we announced a partnership with the Chamber, joint effort between the Chamber of Commerce, Cincy USA, and the Health Collaborative to stand up what we're calling the Regional COVID Communication Center, the RC3. And our aim is not to have a centralized place where all communications flow from and that we're suddenly the grand poobah, but rather to be supportive to all of the multiple communication channels that are indigenous to our community, and to help leaders have access to people like Peter and other experts who understand how to interpret the data, to make sure that we have a cohesive messaging strategy that has a cadence, almost like a campaign. So what we would ask over the next week or two as we stand this center up that you would view it as your go-to resource when you're communicating about COVID-19, so that we're all kind of in the same on the same page regarding messaging. And that is going to be jointly sponsored by the hospitals, the business community, and hopefully some of our local philanthropic organizations.
This is a good segue into one of my questions is anybody else doing that? Any other cities? My question is, how do we stack up? How are we doing? One of the things that we at Centrifuge and through the vehicle startup Cincy, which how we refer to the entire ecosystem, was we're always trying to compare ourselves with our peer cities, right? Those that are in our geographic center, but also model us from a demographic standpoint. So we're looking at what's Columbus doing, what's Indianapolis doing, what are groups in Kansas City doing? How are we stacking up from a communications and a response standpoint?
Well, there's several, dimensions to that question, I guess. And so I think there are some ways that we're really outstanding and other ways that we've got work to do. So that's the high level answer. I can give some examples. Indiana, really by virtue of the way that Indiana is structured, anything in Indiana, you basically start it in Indianapolis and just bleed it to the edges. And so it's inherently more coordinated, whereas Ohio, we have this nation state with three capitals, if you will, and then we got Kentucky and Indiana. So on the biomedical informatics front, Indiana has really been a front leader in pulling together data sources like we showed in that graphic, and we're learning a lot there. Those guys are buddies. They happen to have an institute called the Regenstrief Institute at IUPUI, which is a long-standing tradition in health IT. And actually, for entrepreneurs who might like this story, Mr. Regenstrief was the inventor of the front-loading dishwasher. The whole reason we're able to have our dishwashers loaded from the front was because of Mr. Regenstrief, and he was an immigrant. And when he amassed his fortune and was about to pass away, he believed that adding technology, this was like in the 60s, so technology was limited, to the health sector is something that we need to do. And so to this day, the Regenstrief Institute takes his entrepreneurial mojo and really informs the world. In particular, their claim to fame is all the laboratory codes are coded with a shared ontology that everybody in the world uses to tell hemoglobin A1C from some other lab tests. And Regenstrief manages that code set called LOINC codes. There's a little trivia for you.
Yeah, my kids are
anyway,
gonna love that
on the communications front, Massachusetts is doing great. Yeah. So we're trying as best we can to take our head up from the the day-to-day and try to learn from across the country and even the world on testing protocols, on communication protocols, et cetera.
Yeah.
As an outcomes-oriented person, I guess I would say that one way of assessing how we're doing is looking at our results relative to other places. And, we're certainly not as bad, thankfully, we're not as bad off as Texas or Arizona, but we're also not as good as Massachusetts or Rhode Island or New York right now. And we've got to say they have extremely well-developed public health infrastructures that I think may have contributed to the ability to respond in many ways.
So Peter, my next question was for both of you, but I think you may be able to answer this a little bit. So the hospitals that have that flex space, that's one thing that me as just a general citizen never really think of. Same thing with like an airline that has certain capacity thresholds, or a hotel that typically will overbook, banking on the fact that people don't show up for their reservations. Is that a general agreed upon capacity limitation for a hospital, or does each hospital have some discretion to say where they are in that metric, that it's 80% is normal for us?
Yeah, I mean, hospitals are obviously very complex places to run because they're a combination of very high-tech healthcare as well as running what amounts to a hotel function. So your ability, and it's extremely expensive, so the ability of hospitals to actually keep their beds filled and at a high level is an important piece of the business. So hospitals spend a lot of time and effort trying to figure out how to balance the number of people who are coming in with their capacity, and the challenge has to do with the routine, more elective demand, and then being able to accommodate surges that happen, for example, every year in the winter when it's flu season, there are more people who will get admitted to the hospital. So the hospitals are constantly trying to manage this. They typically will run at a pretty high level of capacity, 80%, 85%. In the winter, they may be running 90 or 95%. And so they all have the ability to add additional space in the hospital, places that might be used as a post-surgical unit, for example, might in the winter under a condition of surge be opened up into a ward where you could put more patients. And the work that's going on right now in the hospitals is trying to have an alert system. Having this data coming starts to allow the hospital leaders to essentially turn down the rheostat a little bit if it looks like, you know, we're on a trajectory where we are going to be hitting 90 or 95%. Well, now we better start putting off elective cases so that we can accommodate new patients.
Yeah, Eric, and I would say that if there's one issue that the local media is probably most frustrated with us about is capacity estimates, because of that variability. It's so easy to misinterpret. And so if we were to cite that we're at 85 capacity, then that would be probably the story. But the reality is, as Peter indicated, we can flip med surge to ICU, and there's all kind of other variables hospitals can modulate to accommodate the surge. So we refrain from reporting out that statistic, even though it's, clearly it's of interest to the community.
Right. No, there's some flexibility there. No, you guys hit it. That's what I was going after was, how to kind of factor that in.
The one other message that we want to put out is that one of the reasons why it's really important for everybody in the community to participate in this is that what we don't want to be in the situation of doing is holding people off from the care that they need. And if things get out of control with COVID, then that's actually what's going to happen. That's what will start to happen, that people that people who are sick, who need care, just won't be able to get it for so-called elective or even more urgent procedures.
Right. Okay, I have one more question for you guys as we wrap up. But before we get to that, there will be a survey. Just to remind everybody, the survey that's coming out. Thanks for your feedback. Thanks for your participation in this. Next big Centrifuge event is our simulcast with Procter & Gamble's Signal Conference coming up July 15th and 16th. My question for the two of you is, what are your predictions? This is time to prognosticate a little bit here, but any predictions for the winter? Do you see us maintaining the course, or just what do you think?
Greg, do you want to go first? Do you want?
Peter's the expert, so I'll tell you what I think, but then listen to him. It's a hard question to answer, because I'm going to be flippant here, because it's up to you. It's up to all those that are listening. That's the primary driver. To stay flippant, there are two factors that will affect the future growth of COVID-19. One is how dense the population is, and two is how dense the population is. So, it's like, how sophisticated do we as a community want to be about this? And that's going to be the answer. All that said is, all the smart people seem to be very concerned right now. And I'm not smart, but I would count myself in the concern group. If this fall we had anything near what we had before, plus the normal flu season, plus and then delayed. Over to you, Peter.
Yeah, I mean, I would just say right now we're in a kind of fragile period. I think what's going to help us do well is the opportunity to learn quickly. We've got to be able to, the better we're able to use the information that we get and actually act on it and then learn from it, the better off we'll be as we go into the fall and the winter. And, it's another way of saying that what Craig said is that in many ways this is in our control, but you have to appreciate that, learn from it, and get better.
Great. Well, I don't think there's any more questions. So again, I appreciate everyone's time. Appreciate Craig. Thank you for taking the time. Good to partner with you again. Peter, thanks for your time. Nice to meet you and work through this process. And I really appreciate what both of you and all of your organizations and really everybody in the ecosystem is doing to prepare themselves and to be better aware of what we need to do to continue to go forward. So that's it. Thanks, everyone.